Thank you so much for inviting me to this conference. I'll be talking about managing patients with epilepsy and comorbidities. I'm going to turn off my video so we can just concentrate on the slides. These are my disclosures and the learning objectives for today. Basically, what I want to do is start with a framework for thinking about epilepsy and comorbidities and how epilepsy is related to other problems that affect people with epilepsy. And so I want to then talk about the two main arms of comorbidity treatment. One is how to treat seizures in the presence of comorbid medical and neuropsychiatric conditions, and the other is how to treat very common neuropsychiatric conditions that arise in the presence of epilepsy. And I'll start with this epilepsy map that I made. This is my mental map of what I do every day in treating children with epilepsy, starting with making a diagnosis and really focusing on what I think are the three pillars of what we do, which is trying to discover the etiology of epilepsy, treating the seizures, but also managing the comorbidities. And under seizure treatments, there are really four different types of or categories of therapy that we talk about. One is medications, of course. The other is dietary therapies, the ketogenic diet and related therapies, epilepsy surgery, and stimulation devices. And all of these are affected by what the etiology is and by what the comorbidities are of the person with epilepsy. So you can see how these are all related. I also want to show you this slide, this graph, that highlights the enormous growth in the availability of anti-seizure medications over the last many decades. We used to call them anti-epileptic drugs. Most of us have now switched to calling them anti-seizure drugs or anti-seizure medications because, unfortunately, at this point in time, we really don't have any medications that affect the underlying predisposition to seizures or affect the core problem of epilepsy. They really just treat seizures or keep seizures from happening. And so that switch highlights that fact. And even with the enormous growth that we've had, we continue to have enormous growth of anti-seizure treatments, with more and more coming down the pike every year. And while this is a great problem, this is why this is a very good thing, it also presents some interesting new problems of the potential side effects of using these medications, the potential problems that you get with using them together. And so just increases the complexity of how we think about treating comorbidities in epilepsy. So what is a comorbidity exactly? What do I mean when I say that? It's a condition that occurs during the course of the disease of interest, in our case, epilepsy. But you can see that there are many different things that could potentially mean. For example, you can have epilepsy and then you can have another disease that's completely unrelated in any way. But your treatments for epilepsy may affect that other disease, and the treatments for that other disease may affect the epilepsy. And so it's important to think about all of the disorders that a patient has and not just the one that you are treating. I'd like to go through these other mechanisms of how comorbidities can be related to epilepsy in a little bit more detail. So sometimes comorbidities can lead to epilepsy. Diseases can lead to epilepsy, and these are causal mechanisms. So, for example, you can have direct causal mechanisms. For example, Angelman syndrome can cause epilepsy. SCN1A mutations can cause epilepsy. Brain tumors can cause epilepsy. In that case, I don't really think about the comorbidity as a comorbidity, but really as an etiology. These are etiologies for epilepsy, and they may also have other related complications or comorbidities. There are also ways that other disorders can have a complication that then causes epilepsy. So for example, children with congenital cardiac disease may have strokes and brain injury leading to epilepsy. Or patients may have cancer leading to brain metastasis, which can cause epilepsy. Sometimes epilepsy results in a comorbidity. For example, epilepsy can causes seizures, of course, and that can result in dental injuries, skeletal fracture, or aspiration pneumonia. And I really think of those more as complications. Sorry, that didn't show up. As complications more than comorbidities. But epilepsy treatment, in this example, topiramate, can also cause comorbidities with their side effects. So for example, kidney stones. Sometimes both epilepsy and the treatment can lead to the comorbidity. So for example, epilepsy treated with levetiracetam may lead to depression or may exacerbate, whoops, that was supposed to be another arrow there, may exacerbate underlying depression. Sometimes there are shared risk factors for epilepsy and a comorbidity. And in this case, again, the risk factor is really an etiology. So for example, microdeletion syndrome such as 16p11.2 can lead to epilepsy, but can also commonly cause autism. Perinatal hypoxic ischemic injury can cause epilepsy, but often results in spastic quadriparesis, intellectual disability, or cortical visual impairment, all of which affect the child's day-to-day life as much or more than the epilepsy. And then finally, there are some instances in which there are really bidirectional mechanisms where the comorbidity is related to the epilepsy. For example, a child with intellectual disability is at increased risk for epilepsy, but epilepsy may also cause or worsen intellectual disability, either by independent mechanisms, through seizures, or through treatments. And there may be some underlying shared etiology or susceptibility. So just keeping all of these different ways of epilepsy and related related disorders in mind can help you think about how to search for and treat comorbidities, because what the main point I'd like to emphasize going forward is it's not just about treating the seizures. It's really important to treat all of the other problems that come with epilepsy as well. So how frequent are comorbid disorders in children with epilepsy? Well, this is one of the largest and most rigorously performed studies, which was a Norwegian population-based study looking at a very large number of children with epilepsy and then evaluating what other disorders they had. And as you can see, comorbidities of all sorts were very common. Medical disorders occurred in over half, other neurologic disorders in nearly half, and developmental and other psychiatric disorders in nearly half. And some of the estimates, in fact, were a little lower than have occurred in other studies. For example, in their estimate, ADHD only occurred in 12%, but in most other estimates, ADHD and epilepsy occurs in almost 30%. And in some disorders, such as tuberous sclerosis, ADHD has been reported to occur in 70% of patients, or 2/3 of patients. So shifting slightly, I'd like to start thinking about specific examples of how we can treat seizures in the face of comorbidities, now that we know that over half of patients have other medical disorders. So the first tenet, the first principle is avoiding specific side effects that may be particular problems in that comorbidity. So in other words, first do no harm. So let's take this case, which is based on an actual patient that I just saw last week. This is an 11-year-old girl with Friedrich Ataxia, which, as you know, is a genetic disorder caused by triplet repeat expansion in the frataxin gene, which causes abnormal iron trafficking in mitochondria and causes not just a progressive neurologic disorder of balance and sensory perception and motor function, but also predisposes to cardiac dysfunction. And this patient, in fact, had cardiomyopathy, which resulted in a right middle cerebral artery stroke when she was age 5 years old. And from that, she now has treatment-resistant epilepsy. She has just one seizure type involving, this is supposed to say left arm and face clonic jerking, alteration of awareness, and those seizures occur 2 to 3 times per week. A first attempt at treatment with levetiracetam was not successful, and she's currently taking, when she was sent to me for evaluation, she was taking oxcarbazepine and lamotrigine, both at relatively high doses. And she'd had a recent worsening of her ataxia and is now confined to a wheelchair. So what should you do? Well, when I look at this situation, I think not only are the medications not helping to get rid of her seizures, they also are potentially causing side effects. And so you always ask first, is it the medication that's causing her recent decline? And then you think about the drug mechanism of action. So both oxcarbazepine and lamotrigine are sodium channel blockers. Lamotrigine, of course, has other mechanisms of action, but its main mechanism of action is sodium channel blockade. And at high doses, sodium channel blockers can cause ataxia, dizziness, or other symptoms attributable to cerebellar dysfunction. And then when you stack 2 sodium channel blockers on top of each other, and on top of progressive genetic ataxia and hemiparesis from a stroke, you can see why there would be a significant worsening of motor function. So what did we do? The plan was to wean off of oxcarbazepine and initiate an anti-seizure medication in its place with a different mechanism of action. In this case, I started clobazam, which is a benzodiazepine and thus acts on GABA receptors, but other choices are possible as well. Let's think about another case. In this case, there's an 8-year-old boy with autism spectrum disorder and new onset epilepsy. He's being evaluated, he's being treated for attention deficit disorder, and he has substantial behavioral difficulties at home and at school. His seizures are described as starting with a behavioral arrest, left hand automatisms, head version to the right, then progression to bilateral tonic-clonic seizures lasting 2 minutes. So given this story, which medication would you start? The 8-year-old with new onset focal epilepsy. Well, here, the 2 most commonly prescribed anti-seizure medications for new onset focal epilepsy are oxcarbazepine or levetiracetam. And I know that in many other parts of the world, carbamazepine is used more often than oxcarbazepine. And here, lamotrigine is a distant 3rd place to these 2. While there are no good comparative effectiveness studies of different anti-seizure medications for new onset focal epilepsy in children, we think that their efficacy, meaning how well they work for seizures, is approximately equal. So the choice should be made based on potential adverse effects and comorbidities. So when I think about this case of a child who has an underlying neurodevelopmental disability and who has ongoing behavioral problems, oxcarbazepine is certainly preferable to levetiracetam because of this behavioral comorbidity. In other words, don't make things worse. So what about a different situation? What about other situations where you have to think about which medications you're going to pick based on comorbidities? And the principle of this one is treating multiple conditions at once, or as the saying goes, killing 2 birds with 1 stone. So let's discuss this case. This is a 17-year-old girl with new onset epilepsy. She's typically developing and has no apparent epilepsy risk factors. She does have migraine headaches, which have been severe enough to cause some missed days of school. She takes ibuprofen multiple times weekly for headaches, but she's not taking any other medications. And her physical exam is notable only for being overweight, but her neurologic exam is normal. Which anti-seizure medication would you start? Well, I just said that here in the US, new onset focal epilepsy is treated most often with oxcarbazepine or levetiracetam. I think I neglected to mention in this case that I didn't say what sort of epilepsy she has. We can presume it was focal or generalized here. But think about her comorbidities, her migraine and her overweight. So in this case, I would consider a medication like topiramate, which certainly can be used first line to treat epilepsy and also has effects to prevent migraine and can also serve as an appetite reduction agent. Other medications that you can think about in people with migraine include valproate, but certainly in a teenage girl, this would not be a first-line choice because of its teratogenicity risk. And it also isn't preferable in this case because it can cause weight gain or increased appetite. So the principle is, if you can think of a medication that has the potential to treat not just the epilepsy, but some other neurologic problem the child may have, then that might be the preferable choice. All right, so now let's get down to thinking about how to treat seizures when you're dealing with other organ system dysfunction. Starting with seizures and kidney disease. The first thing to figure out in a patient with kidney disease who may be having seizures is, are these acute symptomatic seizures or is this epilepsy? Because certainly kidney disease can have lots of ways of causing acute symptomatic seizures. Uremia may be associated with seizures. Electrolyte disturbances, very common in kidney disease, can cause seizures, particularly hyponatremia, hypomagnesemia, hypocalcemia, or hypo or even hyperglycemia. Another mechanism may be posterior reversible encephalopathy syndrome, which is seen often in kidney disease in the context of hypertension, but also in the context of kidney transplant and transplant medications. Another mechanism by which kidney disease might cause acute symptomatic seizures are coagulopathies leading to cerebral hemorrhage. So always important to think, are these seizures, does this person have a history of epilepsy or risk factors for it that are separate from the kidney disease, or are these acute symptomatic seizures? Because certainly you would treat them very differently. And in the case of acute symptomatic seizures, you may employ anti-seizure medications, but you would certainly also be thinking about how to reverse or correct the underlying complication. All right, now, kidney disease and anti-seizure medications. So if you need to use anti-seizure medications in a person with kidney disease, you have to think about a couple of things. First is there renal toxicity, and what other renal effects might these drugs have? So there are actually no commonly used anti-seizure medications that are directly nephrotoxic outside the specific situation of an idiosyncratic acute hypersensitivity syndrome. And those reactions can cause interstitial nephritis and have been reported with many of the older medications like phenobarbital or phenytoin. Excuse me. But other anti-seizure medications can affect the kidneys in other ways, or affect things related to the kidneys. So for example, topiramate and zonisamide can cause renal stones. And while typically they're detected before they become obstructive and thus cause secondary kidney disease, it is possible for them to cause some renal impairment. Oxcarbazepine and related drugs such as eslicarbazepine can cause hyponatremia. And so you may not want to choose those medications given that risk in patients who have had problems with hyponatremia related to kidney disease. So other things that you need to think about when choosing a medication in patients with kidney disease include specific aspects of pharmacokinetics. One is protein binding. If a patient is on dialysis, the levels of a highly protein-bound anti-seizure medication may fluctuate wildly based on if they've just had dialysis or not. Another factor is the percent renal clearance. So dose reduction of an anti-seizure medication is needed when a parent drug or active metabolite is excreted at least 30% or more unchanged in urine. And the classic example of that would be levetiracetam, which is mostly excreted unchanged in urine, and also with the remainder undergoing some degradation in serum, but not in the liver. For levetiracetam specifically, a GFR less than 15 increases the half-life from about 7 hours to about 25 hours. So dose reduction is needed in that circumstance. Also, hemodialysis removes about 50% of levetiracetam, so a supplemental dose may be needed. So you can see how even with a medication that we think is relatively straightforward to use, it can be complicated in kidney disease based on how severe the kidney disease is and what treatments the patient is getting. So drug levels may need frequent monitoring in patients with epilepsy and kidney disease, and importantly, including the free fraction of drugs that are highly protein bound. Here are the drugs with the highest level of renal elimination: gabapentin, levetiracetam, pregabalin, which is a prodrug of gabapentin, topiramate, vigabatrin, and felbamate. And so particularly with all of these agents, care should be taken with dosing and dose adjustments. So let's think a little bit now about seizures and hepatic disease. So again, if you have a patient with liver disease and they are having seizures, you have to think about, are these acute symptomatic seizures due to an acute problem arising right now, or is this epilepsy? Are these unprovoked seizures? Based on the patient's history and other evidence that you can glean. Even in a patient with epilepsy who has seizures, if they're of a different type or of increased severity, it's worth thinking about whether these are acute symptomatic seizures on top of the existing epilepsy, because they might be caused by complications that need immediate attention, such as coagulopathies leading to cerebral hemorrhage, or hypo or hyperglycemia. Hepatic encephalopathy itself can cause seizures, and in fact, non-convulsive status epilepticus is common, which is why many of these patients should be monitored with EEG monitoring in ICUs, just as Dr. Avon was talking about. So what do you do about anti-seizure medications in the context of hepatic disease? Well, the first thing to think about is, are these medications toxic to the liver? It's actually, even though anti-seizure medications have a very bad reputation when it comes to liver toxicity, it's actually pretty rare and idiosyncratic for the most part. The two famous agents being valproate and felbamate for their risk of hepatic toxicity. But even in those cases, it's quite rare. One problem that can arise that leads to liver dysfunction is DRESS, or a hypersensitivity reaction, that's specifically drug reaction with eosinophilia and systemic symptoms. Carbamazepine is the most common culprit in this disorder, although other aromatic anticonvulsants are also implicated. And the treatment of a patient with epilepsy who is having this drug reaction and has liver dysfunction can be quite tricky. Sometimes you can get a transaminitis with anti-seizure medications, but that doesn't always mean that you need to discontinue that anti-seizure medication. One well-known recent example would be cannabidiol, which became available here in the US as a pharmaceutical product, Epidiolex, in the last few years for Dravet syndrome and for Lennox-Gastaut syndrome, and now also for tuberous sclerosis. In the original regulatory trials, a number of patients started on cannabidiol did have increases in liver enzymes, Very, very rarely was it a clinically significant increase, and they almost always occurred in patients who were also on valproate. And discontinuation of the valproate showed an improvement in the transaminitis. So it's thought to be there's some specific mechanism related to the concomitant use of these two agents. And so you don't necessarily need to get rid of an agent if it's working, but think about the combination of anti-seizure medications that you're using, and maybe monitor but keep the drug as long as the transaminitis is not at a clinically significant level. Anti-seizure medication doses do need to be adjusted in hepatic dysfunction because many, many seizure medications undergo liver metabolism of different types. And it's too complicated to remember exactly what to do for each one. So these are situations where you definitely rely heavily on looking things up and rely on your colleagues in clinical pharmacology. But a few principles are that with high protein binding, drugs that are highly protein bound in a person with hepatic disease who might have lower serum protein levels, that can result in increased free levels of the drug in those patients, and thus higher effective levels that the CNS is seeing than what may be reflected in a total serum level. And so you may need to carry out frequent surveillance of levels and of the potential toxic effects, such as measuring effects on hepatic function. And it's important to remember that free levels and protein bound level, the total levels should be checked often. And preferentially use drugs that are not reliant on the liver, such as levetiracetam, as we just spoke about. Okay, what about seizures in cardiac disease? Well, this is an interesting situation because there are many circumstances in which cardiac disease can cause things that look like seizures, for example, syncope or arrhythmias. You can have acute symptomatic seizures when you have a stroke, for example. And then there are certain epilepsy overlap syndromes, certain channelopathies, which can cause seizures, can also potentially cause cardiac arrhythmias. So how do we think about cardiac disease in anti-seizure medications? Well, one thing to think about is arrhythmias related to sodium channel conduction effects. These are just examples. All of the drugs that affect sodium channels have the potential to cause arrhythmias if there are other predisposing factors, including other medications that can cause arrhythmias in the same direction. Phenytoin, of course, is also well known for having potential cardiac effects with fast or too fast IV administration, including hypotension and bradycardia. Carbamazepine at toxic levels can prolong the QRS and lead to ventricular arrhythmias. Thus, patients who present with carbamazepine overdose or carbamazepine toxicity should have cardiac telemetry until their EEGs, until their EKGs and their carbamazepine levels normalize or disappear. And then lacosamide, one of the newer generation medications, is known to have small dose-related increases in the PR interval. But interestingly, even though many people do EKGs before starting this medications, in none of the regulatory trials was AV block reported as a consequence of the PR prolongation. An important new drug to know about the potential cardiac complications of is fenfluramine, which was approved in the US just this past year in 2020 for the treatment of Dravet syndrome. Its mechanism is as a serotonin releasing agent, so it's a novel mechanism. It was actually previously on the market here for weight loss back in the 1980s, but it was removed from the market because of reports of cardiac valve disease in patients who were taking it. Thus, in the regulatory studies for Dravet syndrome, cardiac echo was required at regular intervals. And in fact, no patients developed cardiac valvulopathy, although a few developed very trace mitral regurgitation. And no patients developed pulmonary artery hypertension that was sustained. However, because the risks are still considered present, in the US, prescribing of this medication requires patients to undergo cardiac echo monitoring. All right. In the last topic or last principle of treating seizures in the face of comorbidities, I want to bring up the point that sometimes we need to think beyond medications. So I want to go back to case 1, my 11-year-old patient with Friedrich Ataxia and MCA stroke, who now has pharmacoresistant epilepsy and treatment side effects. So what else can be done? We need to think about other categories of treatment beyond medications. And in this case, I am thinking about evaluating her for the potential for epilepsy surgery, and specifically hemispherotomy, because we know that even though we have many other medications we can try for epilepsy, the chances of her becoming seizure-free with a 3rd, 4th, 5th, etc. attempt at medication treatment is unlikely to lead to seizure freedom. And based on her semiology and EEG findings, which I didn't present, I have a strong suspicion that her seizures are indeed arising from her very damaged right hemisphere, and that her left hemisphere is as healthy as it can be. Of course, she does have a progressive neurologic disorder, but she still has many years or decades of life ahead of her. And seizure freedom could lead to a hugely increased quality of life for her, especially if it means not having to be on medication at all, on seizure medication at all. So definitely important to think about other treatments that could result in lowered medication use or even seizure freedom off of medication. Let's switch gears and talk about finding and treating comorbidities of epilepsy, because this is just as important as treating seizures. Many, many studies point to the impact of the comorbidities of epilepsy, particularly the cognitive, psychological, behavioral, and social comorbidities, as impacting day-to-day life even more than seizures in many patients. So this is a sort of a map of what I think of as the common comorbidities of pediatric epilepsy. Certainly learning disorders, intellectual disability, and autism are really at the top of that list, as is ADHD. But there are also issues with social isolation and independence or lack thereof, which I know isn't really a biologic comorbidity, but is hugely impactful on other things, such as mood disorders, depression, and anxiety, and also just on the overall quality of life of that patient with epilepsy. Epilepsy can certainly be associated with sleep problems, whether it's related to seizures or to medications or to psychosocial circumstances, or even autism, intellectual disability, and learning disorders, which are also highly associated with sleeping issues. And that can, of course, have many multi-directional effects, meaning sleep problems can worsen seizure frequency, and seizures can certainly worsen sleep problems. And then one common set of physical or medical comorbidities that come up are fitness, bone health, and the potential for injury from seizures. So let's consider a couple of these things, and I want to show you a video. This is case 4. It's an 8-year-old healthy boy who presents with new onset staring spells. He's undergoing an EEG. As you can see here, his background is normal. He is awake. He's not hyperventilating. And suddenly, he has this finding on EEG, and I don't know if you can see it on video, but he's blinking and he has a few mouth smacking movements. And then he's finished and he smiles at the technologist. So what was that? I'm sure everyone can recognize that this is an absence seizure. And in fact, this boy had classic childhood absence epilepsy. For some reason, he was treated with valproate. 2 months later, he returns At this point, he has no absent seizures with hyperventilation in the office, and a routine EEG is normal, including with hyperventilation. But in the last 2 months, his school performance has severely declined. And his parents asked, but I thought we got rid of the seizures. Shouldn't he be doing well now? So what is going on, and what should you do? Well, it's very important to evaluate for attention deficit hyperactivity disorder. And it's important to know that in childhood absence epilepsy, this is a very common comorbid condition that is not due to the fact of having brief absent spells in which a person is not aware of what's happening around them. This is independent of that. There's a shared biology to it, but it's attention deficits in and of itself. And then the other thing is, think about what you're doing with your treatment and consider switching from valproate to ethosuximide. And why do I say that? Well, we know from the seminal childhood absence epilepsy trial published in the New England Journal in 2010, which was a randomized control trial of ethosuximide versus valproate versus lamotrigine for new onset classic childhood absence epilepsy without GTCs. In the primary outcome, ethosuximide and valproate both were more efficacious than lamotrigine in leading to seizure freedom in patients and children with CAE. However, in the secondary outcome, which was a test of attention, and granted, this was a very specific test of attention and may not completely reflect the more complicated fact of attention deficit hyperactivity disorder. But in this test, the Conners continuous performance test, ethosuximide and lamotrigine both performed better than valproate, or in other words, valproate had significantly greater adverse effects on attention in children with treated and successfully treated childhood absence epilepsy. And for that reason, ethosuximide is the preferred first-line medication for CAE, as long as there aren't generalized tonic-clonic convulsions. And in the case I just presented, though the valproate may be effectively treating the seizures, it is causing potentially causing substantial side effects of ADHD. The other thing that should be considered in that case is treating the ADHD. So as I mentioned before, about most estimates say that about a third of children with epilepsy have ADHD. And there are a few differences in ADHD in children with epilepsy compared to the general population. One is that the inattentive subtype is more common, and boys and girls are equally affected. The risk factors for ADHD and epilepsy is earlier age and epilepsy onset has higher risk than older ages, drug resistance, which may also mean polypharmacy. Generalized epilepsies or frontal lobe epilepsies have a higher risk of ADHD. In utero valproate exposure, if a mother was on valproate during the pregnancy, that child is at greater risk for ADHD. And also certain medications can worsen ADHD, including valproate, phenobarbital, and levetiracetam. So in a child with epilepsy where you suspect ADHD, the first step is making a diagnosis, of course, and you have to differentiate, as we just did in this case, ADHD from absence seizures. Children are often referred to us for concern for absence, but actually have ADHD. You have to differentiate ADHD from other cognitive or learning impairments, for example, executive functioning or other frontal lobe functions. And I rely on my colleagues in behavioral health, so my neuropsychology or psychology colleagues, to help with the evaluations for this. Differentiating ADHD from anxiety is also important, and differentiating ADHD from effects of sleep disorders, including chronic sleep deprivation, because each of these will, of course, have a different approach to therapy. If you do diagnose ADHD, the next step is treatment. So as we discussed, you can avoid certain medications if possible, such as valproate or even levetiracetam, although it's not a hard and fast rule. It's just something to think about. Try avoiding polypharmacy, which can certainly predispose to worse ADHD. And don't there's this common misconception that somehow stimulants are not allowed in patients with seizures because they may worsen seizures. But in fact, that is false, and treatment with stimulants, I should say stimulants, is safe and efficacious. Methylphenidate, there's actual evidence for efficacy based on randomized controlled trials in children with epilepsy. And in those trials, worsening of seizures was relatively uncommon, and when they occurred, they were mild and limited. So don't be afraid to use stimulants to treat ADHD in children with epilepsy. Certain epilepsy etiologies have specific comorbidities, and so you need to remember those as well. Of course, you know the famous ones. Tuberous sclerosis is associated with other organ dysfunction, such as renal angiomyolipomas, or a very specific type of lung disease that occurs typically in women with tuberous sclerosis. Sturge-Weber syndrome, of course, is associated with glaucoma. And so in these disorders, where there are specific comorbidities, periodic surveillance for those comorbidities is needed. And so when you are seeing these patients, if they are not being referred by their pediatricians for surveillance of these comorbidities, it's important for you to do that. And then, of course, there are certain disorders which are associated with the worst comorbidity, which isn't really a comorbidity, but sort of the ultimate complication, which is death, or in this case, sudden unexplained death in epilepsy. And SCN1A, for example, epilepsies related to mutations in that gene are associated with a substantially increased risk of SUDEP. And so this is all just to say that it's very important to continue searching for an etiology. Even though we don't find an etiology of epilepsy in about half of the patients we take care of with epilepsy, it's important to keep searching, because not only will that help you counsel a family about long-term prognosis, but may also help you look for specific comorbidities that where the risk, where they can be treated or the risk can be reduced. And then as we are getting near the end, I will bring up one other topic, which is bone health in pediatric epilepsy. So epilepsy is associated with high rates of low bone density, and bone density, the maximum accrual is in childhood and adolescence, or before the age of 25 years. And so this is a topic that is relevant to us, even though the consequences of low bone density is often not seen until later ages. However, fractures do occur 2 to 3 times more often in children with epilepsy. It's not clear that that is just due to bone health problems. There are many reasons for that. For example, low weight bearing in patients with who are wheelchair bound. The reasons for osteopenia in patients with epilepsy is likely multifactorial. The mechanisms are in fact poorly understood, but they are thought to include certain medications, certain medication exposures, particularly older anti-seizure medications like valproate or carbamazepine. Patients with epilepsy may be less mobile, may have less outside activity and thus less sun exposure, may have poor nutritional intake leading to lower levels of vitamin D, which is essential for signaling bone density formation or calcium deposition in the bones. Unfortunately, right now, there's no consensus on if and when to evaluate bone density with DEXA scans, for example, and there's no real consensus on when and if to check serum vitamin D25 hydroxy levels. But I do supplement many of my patients with vitamin D3, especially if they are on medications that put them at higher risk for low bone density or fractures, or if they have other factors leading to increased risk of fractures. Vitamin D3 supplementation is absolutely necessary with the ketogenic diet, which is also known to have an increased risk of osteopenia. And encouraging weight-bearing exercise whenever possible is also important. So in summary, it's really not just about treating the seizures, as all of you know. You should find an etiology when you can, because it can help detect relevant comorbidities sooner. It's important to search for comorbidities. You have to ask about medication side effects. You may need to do laboratory or diagnostic testing to look for treatment side effects. You should screen and refer for further care in children who have behavioral psychiatric comorbid conditions. And you need to keep screening over time, because while many behavioral and psychiatric comorbid conditions are present at epilepsy onset, other comorbidities may not be, including depression and anxiety. It's important to know how to adjust treatment based not only on efficacy for seizures, but also based on tolerability and side effects on comorbidities, whether for good or for bad. And much, much more work is needed for us to understand the biology of underlying neuropsychiatric comorbidities and epilepsy in order for us to better treat them. Thank you so much again for inviting me to give this talk. I look forward to being present for the question and answer session a little bit later in the early afternoon. But you may also email me at the address you see here if you have any questions.